morning. Thank you for the opportunity to share with you my bad moments. How do I change this? Go forward.
The green button.
The green button. Okay. We have no disclosures, and we all know the advantages of hip resurfacing that preserves bone, and we also know that nothing is forever. So we started resurfacing in Brazil in 2003, and this is one of our initial cases. This is a patient of 38 years old with bilateral osteonecrosis of the femoral head due to corticoids. And so he was operated in November 2003 with a 48 hybrid core cemented, and 2 months later with the right hip. And then we stayed with Harlan Stutz in 1991, 1993, 1996, following his papers, and I was a great fan of Stutz when he was autographing this book. I was only 33 years old, and also a great fan of McMinn. This is a phrase of McMinn, that the bad results of resurfacing are the results of bad resurfacing. So this is the X-ray we had on February after the second surgery, and what is wrong here? Everything is wrong. Why? Because both femoral components are in varus position, unacceptable varus position, and also the bigger the acetabulum, more valgus is acceptable for the acetabulum. And Thomas Gross published this paper about the relative acetabular inclination index, where he classifies for the recap heads a table where he puts the relative acetabular inclination index in the ideal for each size. So this is the table he devised for recap, but I think we can use for Birmingham, from Conserve Plus. And in this case, both femoral components were of 48 millimeters, and you see on the right side it was 62 millimeters, and the other side was also 50 millimeters. So both sides, the acetabulums are in an acceptable position, and both sides of the femoral components are in varus, also in acceptable position. So with that knowledge, we know nowadays that this will be a catastrophe. We probably should revise both hips to prevent all this metallosis, all this non-desirable marrow debris. Well, we didn't know that about that time, so I followed this patient very closely, asking him marrow ions most of the time that I learned with Catherine van der Straten and Kundesmet. And so 13 years ago, this patient was asymptomatic, and he disappeared because of insurance. He didn't have his insurance anymore, and then I had all these follow-ups, and all the marrow ions during that time were normal. Suddenly he starts having pain after 6 months, and he went to 2 or 3 different orthopedic surgeons, and all those other orthopedic surgeons said it was okay. He was okay. He wasn't having pain. He was just following with other doctors, but he felt that his leg was a little bit shortened. And the 3 orthopedic surgeons who saw him said, everything is okay, go ahead. Then he decided to look for me. And we see here that the right femoral component entering varus. And then he became symptomatic. He had more pain, then he decided to look for me. So I asked for the marrow ions, and the marrow ions at that time were still normal. This is interesting because he was having pain, marrow ions were normal. And so we did the revision about a month later, and this is the aspect. There was almost no metallosis. It was very easy to retrieve the femoral component, as we'll be able to see here, and very few tissues, black tissues with a metallosis. What is expected in any kind of prosthesis after 19 years? And so the revision was quite easy, and I end up putting a double mobility. The one that Edwin Su doesn't like, but I like Edwin. Let's hope it's working. So the surgery was was performed just changing the femoral component and putting a ceramic head and a dual mobility from France. So it's a mix of British prosthesis with American stem and French polyethylene. And was very 40-minute surgery. Patient had a very good evolution. And so maybe this presentation should be named by how much acetabular and femoral components malpositioning are acceptable in metal-metal resurfacing. In this meanwhile, I think we should respect the rail index and femoral valgus angles. And this is not a breakthrough, but I don't know how to explain how could this case last so long. Maybe the valgus of the acetabulum was compensated by the varus of the acetabulum. Okay, thank you very much.
And if we could ask Benjamin Donald, confirming hip resurfacing clinical and radiographic outcomes.